born and raised in the U.S. Virgin Islands. She received a Bachelor of Science degree magna cum laude at Georgia State University in 2008. After losing her grandfather to complications with prostate cancer, Dr. Scott was determined to make a difference in the health and lives of men with prostate cancer. Upon completion of her undergraduate degree, Dr. Scott worked with Dr. John Petros at Emory University, where she was involved in prostate cancer mitochondrial DNA research. In 2012, Dr. Scott completed a doctorate in biomedical research at Morgan School of Medicine. Dr. Scott's career has been directed at solving key human cancers by individual genomic discoveries and personalized care. This led her to her current position of GenomeDx, where she is involved in prostate and bladder cancer biomarker clinical analysis. Her other role at GenomeDx has been to educate physicians, scientists, patient groups, thought leaders, and other healthcare professionals on innovative, personalized, and comprehensive therapeutic approaches offered through Decipher Testing. Dr. Scott, welcome.
That's such a wonderful intro. Guys, I am so happy to be here with you this evening. My schedule is pretty booked, as you explained. I travel a lot and educate physicians all across pretty much the U.S., mostly the Southeast area, and some out of Atlanta. But when I first got word from Jim and Ethan about coming out to speak to you guys, my schedule was pretty booked. I was actually heading on the road for a urological society meeting tomorrow. And so I said, how am I going to speak to you guys with me? Because I love educating the physicians, but my heart, their heart is actually speaking to patients like themselves. Again, due to my passion and my history with my grandfather, I actually lost two grandfathers now to prostate cancer, both maternal and maternal. So, hence, guys, I am here to encourage you. I can't wait to show you how the field of genomics has been advancing to kind of help you make clinical decisions and help your physicians to help you determine the right treatment for you. So again, guys, thank you so much for having me. And let's go ahead and get started. So my talk this evening is entitled, Is Decipher Right for Me? Personalized information, and it's entitled Personalized Information for Life. And you will see exactly what I mean when I say this. And so some of the things we're going to be discussing this evening is it's very important to first let you get a handle on genomics versus genetics. So we'll talk about that. And then we'll talk about low risk versus high risk prostate cancer. And then the Decipher Testing by GenomeDx, we have both a biopsy and a post-op test. And are you a great candidate for Decipher Testing? How it can help you, how to order it. And I'm going to talk a little bit more on a little bit behind the scenes and what we like to call a disruptive personalized genomic approach to understanding prostate cancer. And according to our GRADE, which is the Genomic Research Information Database, and I'll explain what all that means in a second. So first, I like to, again, first start with genomics and versus genetics, because it's very important that you understand this terminology, because they're quite different from each other. So what do I mean when or the big term genomics, what does that mean? So genomics is the study of the complete genetic information of an organism and how all those genes in that organism interact with each other and with that individual's environment. So also in more, I guess, layman terms, kind of the activity and interaction of how certain genes in your tumor tissue influences the behavior of your tumor as far as how likely it is to grow and spread. Versus genetics, on the other hand, and you tend to see, when you hear about genetics, you'll see these pedigree hierarchy trees. So genetics is a study of the makeup of single genes and their roles in the way traits or conditions are passed from one generation to the other. So when you're talking about genetics, you're talking about the mutations that are associated with perhaps diseases such as sickle cell disease or cystic fibrosis. But genetics is not all that. It's also how you get your, say, eye color, hair color, skin color, etc. And so just more talking about, in order to more clearly understand genomics versus genetics, you also have to talk about what's known as the central dogma. So the central dogma talks about how DNA is transcribed to RNA and then translated to protein. What does all that mean? So this is I like to call the language of genetics, genomics, etc. So basically right here we see genes, DNA make up genes. First you actually see the chromosome here. Chromosomes are made up of many different types of genes. And genes are made up of DNA. So this helical structure right here. So I like to use this little cartoon to kind of explain what is going on here. So these guys here, you're pretty much trying to build a house, right? So you get the instructions for that to build this house, the DNA here. That DNA is in some form or other language you can't understand. So you speak English, but it's in French, Spanish, German, Russian, whatever, right? And so you can't read this map of how to build a house. So you need someone to translate those instructions for you into English so that you can build this house. That's where RNA comes in. So with the RNA, then the RNA is able to transcribe the instructions and build the house, which we're referring to tonight as the protein. So the protein, so basically the DNA is in the instructions needed to carry out, to be able to carry out and build and make your cells function in your body. So here, when we move on, this is going to make it clear as to how what these genetic and genomic tests out there are actually measuring. So another terminology that you're hearing a lot, omics. So genomics, transcriptomics, proteomics, you're kind of like, again, what does all this mean? So again, the genome are all the genes, as we previously described, in your cell. The transcriptome are all the mRNA transcripts that allow coding for the protein to build a house. And then proteome is all the proteins in the cell. So all these omics are now what's being used to personalize medicine for many different kinds of cancers. And so you have the genome, and then you look at the transcriptome, which our test is looking at, and I'll explain that a little bit later. You have companies that are looking at the antibodiome to kind of personalize, create drugs, antibodies to kind of combat your tumors, cancers, etc. They look at the epigenome, your kind of DNA, the DNA modifications to kind of personalize again treatments for drugs for you. So that's what all this omics that you're hearing about. And then all of these omics, and in order to create these personalized drugs, they're looking at what's called biomarkers. So what are biomarkers? Biomarkers are molecules that indicate normal or abnormal processes, and basically that are taking place in your body, and they may be a sign of some sort of underlying condition or disease. And these biomarkers may be proteins, genes, hormones, any kind of molecules that can affect how the cancer or whatever disease in your body grow. And so biomarkers can be found in your blood, stool, urine, tumor tissue, and other bodily fluids. They may be produced by the cancer itself or by other cells in the body that are responding to the cancer. So either the cancer or perhaps immune cells that are giving off signals saying, hey, the cancer is over here, come over here. And then, so the cancer, now we've talked about the DNA, so the cancer in your body has a unique DNA from the rest of the normal cells in your body. So, knowing that information, researchers like myself were able to identify treatments that would have a positive or a negative association with those biomarkers in your body, thereby being able to personalize treatments specifically on this unique DNA or biomarker profile in your body. So I just wanted to, having said all that, technology is advancing, as you can see. Kind of included a little timeline for fun facts for you. So in 1951, we first got the microscope, so they're able to look at your cells under the microscope and actually look at more molecular structures. Then there was, in the 1800s, the first microscope. They were able to start cutting tissue and different things and looking under the microscope. The DNA, again, was isolated during this time. And then there were like stainings that were introduced that would be able to help you really look deeper at the structures in this tissue that they're looking under the microscope with. And then DNA, the double helix, was founded somewhere there in the 1800s, about 1869. And then you have immunohistochemistry, again, some more stainings, so you can really see these microscopic stuff under the microscope. And then you have the PCR, which was really being able to amplify DNA. So you can be able to amplify our RNA and kind of look more at these structures again and kind of count and see how these genes are being overexpressed, underexpressed. Then came the Affymetrix microarray, kind of the platform that we're using. And I'm going to pass this around, and I just hope, just ask whoever gets to the last, just kind of hold on to it for me and return it to me. But I kind of want you to look at this, so that when I go on further in the talk, you kind of know what I'm talking about. And I'll explain this in a second. And then there was the Human Genome Project in 2003 that were kind of mapping all of the genes in the human body. So that was a project that took place in 2003. So hence all this genetics talk. Yes, go ahead.
I must be confused. I thought that the double helix was found in the 50s.
So there was.
What am I thinking about there?
So there was a DNA. First they were thinking it was like single-stranded, and then later on they discovered, oh, it must be that it's really double-stranded. So maybe that's where the likely.
I think Watson could get the. That was.
Right.
Cool.
Right.
That wasn't 18.
Right. So back then, well, the initial thought of it was kind of in the cell was this molecule. And then later on, they're like, oh, this is DNA. Right. And so, the confirmed reaction PCA3, these are the tests that can help your physicians decide who to re-biopsy. And then, these are the tests that can help you decide who to treat. This is where Decipher fits in with Oncotype and Polaris. And then also, Decipher and Polaris goes under follow-up therapy, as well as I'm going to talk a little bit more about our Decipher grid, because that is unique and actually helps us to personalize your treatment. So, Decipher test, GenomeDx. When did we get started? Who are we? GenomeDx, in that we have the most widely used post-op test. It's covered by Medicare, and we publish on average about 2 to 4 publications a month. That is stellar because usually with certain companies, you kind of get 1 to 2 publications a year. So currently, we have about 3,000 plus patients and about 84 publications that you will be able to Google and kind of find and read if you're interested. And then we have our disruptive approach grid, the largest urological genomic database. So what is our Decipher test? What does it look like? So that little chip that I just passed around to you, that's this genome chip right here. So it looks at the entire transcriptome. Remember I mentioned that word earlier. So all of the coding and non-coding RNA. We get your paraffin embedded tissue, whether it's biopsy or formally fixed tissue from your prostatectomy tissue. And then we extract the genetic material and we put it on that chip, and we are able to get a readout looking at 1.4 million biomarkers on that chip. So the entire transcriptome of your tumor, basically a whole genome snapshot, or what I like to call the genomic fingerprint of your tumor. And with this fingerprint, we are looking at several different pathways. So we like to let pretty much the tumor tell us what's important. Let the tumor tell you if you have an aggressive or less aggressive tumor. And so, how is Decipher, how does your physician utilize Decipher in your patient management profile? So, you just had a biopsy, it's positive. Your physician runs a Decipher test. This Decipher test comes back and it's able to help your physician decide whether you're a great candidate for active surveillance or if you require immediate treatment. So now, for other guys, you had surgery and you're thinking, I'm concerned about some of the pathology post-RP. Or you're wondering, do I need further treatment? Will further treatment mean that I'm being overtreated? Your physician can run the Decipher test here, and that will be able to answer those questions. Or perhaps now you've got PSA rise, or you're saying, if I don't get any further treatment, what are my risks for metastasis? Your physician can again run the Decipher test at this point and answer questions such as, will I benefit from earlier radiation therapy after PSA rise? Do I need, am I okay with local versus do I need something a little bit more systemic? Do we have to add on some formal treatment here? These are some of the questions that Decipher can help in your your physician's management of your care. So before I continue, it's very, very important for me to help you to understand. Sorry, but yes, sir.
Is the PSA rise, is that only for post-radial prostatectomy?
Sorry.
Is the PSA rise, is that only for post-surgery, or can that be done with biopsy samples also?
So the PSA rise is for, in that particular, it's invalidated for our post-op test, but what the doctors do is continue to watch your PSA rise following, so let me back a little bit. So sometimes they will, you're watching the doubling of your PSA, so perhaps 8 plus maybe 2, now it's 4, now it's 8. So that's also how they can utilize the Decipher testing on the biopsy level. And so it's very important to understand the accuracy of these genomic tests or any kind of prognostic clinical features such as PSA, Gleason score, etc. It's very important to understand how these tests should be measured. When you're looking at that, to measure accuracy, they use for prognostic tests, they use what's called area under the curve. Area under the curve is the balance between sensitivity versus specificity. So in order to be what's called clinically actionable or relevant in helping to decide risk of metastasis or whatever the measurement may be, you should have an area under the curve of at least 0.7 or better for it to be clinically actionable. And so basically it's on a scale with from 0 to 1, with 0.5 being as if you're flipping the coin, so taking a chance. So when you look at how Decipher compares first over here to the right, our Decipher post-op test compares to other clinical features that your physicians are currently using, you see that Decipher has an area under the curve in this bar graph here of 0.79 compared to, say, surgical margins, which is about 0.5, almost like flipping a coin. Your physician is using that to decide, hey, will this guy metastasize? And also you take a look at Gleason score or extra prosthetic extensions. All these are great. I'm not saying that they're not good markers, but now that genomics are moving into the field, they're a little bit more accurate than what physicians were using before. Because now you are first looking at you're able to look more with genomics at the molecular level, kind of what's going on in the biology of your tumor. And so, go ahead.
So if you get this done, you're comparing these results versus the Gleason score that you got.
That's a great question, Nick. So Decipher is completely independent, and that's what makes us different from some of the other genomic tests that are out there. It's independent. It does not require any input of these clinical physician can use it to compare with what's going on with the previous clinical features. But the Decipher test is completely and solely based on genomics. It does not incorporate any of those clinical features.
Do you use a whole different bank of physicians?
When you say a whole different bank of physicians.
Like I've got a team that handled my biopsy. Do I go to a different group?
No, if your physician is using Decipher, we can always educate them about it if needed. But usually, they order it and they're kind of working in a team, or they refer you to say the RP surgeon, etc. And any one of them can order it.
Just a curiosity, fundamental feeling. If I'm a physician and I decided to go through this course of determining the candidate from the biopsy test, and then I had something different come in, how do those physicians feel? Do they feel like outsiders coming in to second guess their?
No, it just depends, because you do have some physicians, they are traditional. They have been trained in medical school, so this is still they still depend on the clinical features and they prefer that. But versus those physicians that they welcome new technology, they're like, whatever it is that I can use to actually help in decisions that I can't make using these features. So it's kind of a mix. There are many different, I don't know, like your particular physician or how his choice of treatment, but across the board, I have visited many different practices that are open to genomics versus those that I'm not there yet with genomics.
So it's almost like getting a second opinion.
Right.
But where did you get this biopsy from? Like I did my RP 7 years ago. And in my case, where would you get this biopsy?
So in your case, it wouldn't be you have your prostate removed already, so you'll be using our Decipher Post-OP test. And with that, so let's see. So there are some restrictions on that. You said 7 years ago. You can run the Decipher test if you're having perhaps PSA rise again. That would be where you would utilize the Decipher test, because it's been about 7 years since your surgery.
Well, what do they use for is sample?
Oh, yeah. Oh, I'm sorry. Yes. So it's the paraffin embedded. So 7 years, I think they keep the tissue up to about 10 years. So your tissue should be on file with the pathologist your surgeon is linked to. And then what they're
reading off of that?
Yes, you can. Because formalin is a fixative, and so it's that microtome I explained. So your tissue is preserved. The genetic material that we need to extract from it is preserved. And so it kind of looks like this right here, a little block with your tissue in there. And we get this block, and we're able to remove the fixative from it that's been keeping it protected for the 7 years, and we're able to run it on the chip. You're welcome. Sorry, what's that? There was one other hand. Somebody else.
I saw this word back before you had this mentioned. What is the difference between the Decipher and the Polaris test?
Okay. So with Decipher, they're both genomic tests. Our Decipher test looks at 1.4 million markers, very independent of clinical features. With the Polaris test, they look at CCP, what's called cell cycle progression genes. So I'll back up a little bit to this slide right here. So cell proliferation genes. Whereas we're using the genomic chip, that microchip I just sent around. So it's capturing the entire transcriptome. With Polaris uses PCR, and so they are particularly looking at just the cell cycle proliferation genes, PCR, and then they are looking at markers such as PCSM and biochemical recurrence. We look at a little bit more definitive endpoints, metastasis. What's your chance or likelihood of metastasis post-RP? That was, okay. So, who is eligible to, I'm sorry, I did not finish the accuracy with our Decipher Biopsy test. So with our Decipher Biopsy test, the same thing. recommended area under the curve AC of 0.7 or greater. And so here in this bar graph chart, Decipher is being compared to the National Cancer Comprehensive Network. So that's the guidelines that your physician is currently using to determine your necessary treatments. And so the NCCN created a nomogram containing your clinical features, these clinical features here. And so what we did in this graph was compare Decipher alone, our Decipher Biopsy Test, which has a stellar area under the curve of 0.87. The closer you are to 1, the better you are as far as accuracy. And so Decipher alone, 0.87, compared to the NCCN nomogram, which had an area under the curve, 0.72, not bad at all, and pre-op PSA, 0.67, and biopsy Gleason score like the flip of a coin. However, when we look at Decipher in combination with the NCCN nomogram, we see that there was not much of a change in the area under the curve, and this is showing you that Decipher is actually capturing all that information on its own without need from those nomograms. So who are eligible and who are the best candidates to order the Decipher test? For our Decipher biopsy test, anyone that has been characterized by NCCN as being very low risk through very high risk can order the Decipher biopsy test. For the Decipher post-op test, we are currently indicated for anyone with PT3 disease, positive margins of biochemical recurrence. Yes, sir.
Can you explain what NCCN is?
Right. So that is usually Harrison Field is a National Cancer Comprehensive Network, and they are involved in generating guidelines for current care treatment of prostate cancer. And so most of your doctors tend to use this as their gold standard on determining how to treat your prostate cancer. So here, and just to notate here that our post-op test is covered at 100% Medicare. I just kind of wanted to show you how the Decipher test report looks. To the left here, we see this is an example of the Decipher post-op test. And at the top of the Decipher test report, you'll see where they have your patient information. And then here, clinical details from your pathology report. So this is listed here on the Decipher test report, but just to remind you again that our test does not incorporate those clinical features. So they're completely independent, but they're just listed here. So as a reference for your physician, and then so they can kind of use it and then measure it to the Decipher test result. And so here is how the Decipher test result is the continuous risk score from 0 to 1. And each increment, the Decipher lowest goes from 0 to the raw score of 0.45, intermediate risk score 0.60, and then high risk ranging from 0.60 to 1. And so if you come at Decipher low risk, then you're at a lower metastatic potential. If you have a lower metastatic potential versus Decipher high risk, you are a higher risk, you have a more aggressive prostate cancer too. And so with and the same goes for the biopsy test report, it looks very similar. Our Decipher biopsy looks at 2 main endpoints, so 5-year risk of metastasis and 10-year, your likelihood of metastatic disease 5 years post-RP, and also your likelihood or chance of dying specifically from prostate cancer 10 years post-RP. And so here on the biopsy side to the right, we look at 3 endpoints for our Decipher biopsy test. Your likelihood of having high-grade disease. So what does that mean? Do you really have a 3+3 or do you really have a 4+3? We also look at, again, 5-year metastasis like the post-op test. Your likelihood of metastasizing 5 years post-surgery. And again, the 10-year prostate cancer specific death. So just to kind of remind you again, you're the Decipher patient. Your physician orders the Decipher test. They run this microchip. You capture the entire transcriptome of your tumor, all the markers, 1.4 million markers. However, the Decipher test looks at only 22 of those biomarkers. So you're like, hey, what do you do with all this other information here? What do you do with the 1.4 million markers? Well, that is stored in our Decipher Genomic Research Information Database. But I previously mentioned we have the largest urological database. This creates a disruptive approach for us. This makes us different from any of the genomic tests that are currently out there in that with this disruptive approach, we collaborate with almost all of the academic institutions across the U.S. And we have, when I say the largest urological database, we compare it to what's called the Cancer Genomic Atlas, which has about 498 patient profiles. This was back about a year to 2 years ago. Currently, right now, we have 42 tumor expression profiles in our genomic database, so about 30 times bigger than the, this is gold standard, the Cancer Genomic Atlas. And in that, again, we're working with about 300 physicians. We work with about 55 research institutions. And what we do, this allows us to have that collaborative approach and able to bring you new endpoints, such as which patients benefit from radiation therapy, which patients benefit from hormone therapy. So those are all the different kinds of research that are going on with this Decipher grid. And I'll explain this a little bit further.
Can I ask one question?
Sure.
Slide, when you describe the Decipher results sheet.
Oh, yes, this one.
Okay.
Okay.
So this is your, for the biopsy report. This is the result. If you had, after you had radical prostatectomy, right?
Right.
What if you had this first side, you want to have radiation?
So we do have a study. Currently, we're only validated as far as our, and when I say validated, as far as our Decipher test report for RE, but we do have 2 studies that we just published, and we're working to include those eventually on our Decipher test report, but it's not currently as validated for our test report yet. But in predicting the patients that will benefit from first-line radiation therapy.
So these percentages, like your 10-year prostate cancer specific mortality, is based on if you have prostate. If you will go ahead and have a prostatectomy, right?
Right, and have that treatment already. Right.
But if you're active surveillance, it doesn't really tell you.
Right. It just says the Decipher low risk. You will benefit from active surveillance. Sure.
Same topic, different words. To validate this test for the biopsy, you ran the Decipher test on hundreds of folks.
Right.
And you got the numbers. And then those folks had a prostatectomy. And the tissues from the tumor were looked at.
Right.
Now, how were those tissues then determined to be aggressive or non-aggressive to then correlate with the
Awesome question. So let me take this back a little bit and actually. So when we were validating our signature, we looked at men that had no occurrence of BCR metastasis compared to men that had metastasis. Then we looked at the genes that were being overexpressed in those men that were metastasizing, and that's what our test was validated on. So you look at all, you have a control group, and then did not metastasize, and then metastasize. And you're kind of looking at how the genes are on and off in those patients. And then that's letting the tumor speak as to tell you which of the genes are important in deciding which cancers are more aggressive than others.
Doesn't that require us taking another tissue sample from the metastasized site?
From the metastasized site, not sure.
Look it up.
Right, so you look, I understand what you're saying now. So we're looking at outcomes. So most of the validation studies, and I will be quite honest, that is the problem with many of actually all the tests currently right now. It takes a while. Prostate cancer is a slow-growing disease. It takes about 10 to 15 years to get those kind of prospective outcomes. When I say prospective, meaning you take this recent sample of the patient and then you follow it out to 10 to 15 years. All these studies across the board with all these prognostic tests are indeed retrospective studies. So to answer your question, cancer, say 10 to 15 years ago, because we're trying to follow their outcome and look at their metastasis and look at whether they metastasized or not, or had PSA rise following surgery, how many years after, etc. The good thing with our GRID research is actually we started our prospective studies and we have a few in our pipeline, and we are indeed following these men to look at their outcomes. So that data, of course, it takes a while, but we're hoping at least to start to get outcomes within the next 2 to 3 years to kind of show 5-year markers and then following us 10 and 15 years on. But it takes a while to generate that kind of data.
So wasn't the same validation done for recent score too?
So
comparing those scores against.
Right, and you find in literature, that's right, that's exactly how they did years ago to determine, but at the time, that's all, you start off with something that's all you can, but you gotta move forward, but that's exactly correct. Right, so they've had lots of prospective studies with that, right? So, let's see where we were.
So why is there such a great difference between Decipher testing and Gleason score?
There is, so with the Gleason score, it's kind of based on, it's more subjective to your pathologist viewing, so human error. So one pathologist you're cutting out, you're looking, especially for biopsy. So that's kind of why we look at your likelihood of high-grade disease and upstaging of it. Because with biopsy, you're looking at, a little sample from the prostate tissue, so it might be a 3+3 depending on where you take it from, but when you look at the entire prostate, it's more a 4+3. Or if you're looking at the pathology, depending on the training of the pathologist, and I'm not knocking them there, they're wonderfully trained, but you will have variations from one pathologist to another. So again, one pathologist might say that's a 3+4, the other one might call it a 4+3. So they're not very accurate. Whereas genomics, there's no input. You're measuring the overexpression or expression, no human involvement in that. So.
Well, mine was a 7. I'm an engineer, just like Ethan. And my first question was, if 6 is a surveillance, and 7 is therapy or surgery, how do you judge that line? And mine was a 3x4. So what you're saying, if I get this Decipher testing, that will give me a better view of
the biology,
which side of that line I'm on.
Right. Well, because I'll show you too, because sometimes you have, and that's why I said no two cancers are alike, and I'll show you some of the data from practices that I've been generating. So sometimes you have a 3+3 guy, and they're low risk, right? And then you have another patient that's 3+3. But that guy's genomic risk score is off the charts. That guy is going to metastasize, and you watch that guy, and you see that the 3+3 guy, same clinical features, same Gleason score, never metastasized versus that other one. So it's kind of like the Gleason score does not capture all the information as far as looking at the different pathways or how fast the tumor will grow, how fast it will spread. Is this tumor able to support itself as far as can it form blood vessels so it can get more blood and nutrients to the tumor? So you're looking at a variety of all the hallmarks that are associated with cancer versus Gleason score. You're just looking at it under the microscope at the surface of the tumor.
So we're here today, August 30th, and I've got a 7, okay, maybe a 6, so I'm putting it off for 2 years or 3 years, and then I come in and get another biopsy, and I'm back to the same point of having to make a decision, but maybe I'll cross the line. So why would I make a decision today?
Right, and that's totally, that's a good one. That's the problem. That's kind of creating when is the best time to have treatment and what conditions should push you to have treatment. And that is actually the debate, right, is what we're trying to solve with these genomic testing. So it's kind of like we can't really tell you that's something like your doctor is trying to decide, and maybe he incorporates, some doctors will tell the patient this is what you should do. Other doctors are, the patient is involved in decision making. So that's where we come in, and we're hoping that this Decipher test can help solve those questions that you are indeed asking. And it'll get clear. I have a few stories here and real life scenarios from some patients in study, and you'll see exactly what I mean with this. But with our Decipher test, Decipher grid, what is grid doing? What are some of the behind-the-scenes research or some of the things signatures that we're able to offer you on our disruptive, unique platform that no other company or genomic test is able to provide for you? So first off, and this we have actually 2 papers out now on this, so we're working again, like I said, for the validation point for our Decipher test report. We're able to determine which men would benefit from first-line radiation therapy. So you had a positive biopsy, right? And now you're deciding, like, it's surgery or can I have our radiation therapy? This is kind of helping your physicians, because sometimes in younger men, they'll encourage or recommend surgery versus in older men, they tend to, kind of tell you, let's do radiation therapy. However, you kind of want to, the concerns are the side effects of some of these therapies, and we not want to be, overexposed to some of the toxicities from it. So these kinds of studies are able to help your physician decide, are you a good candidate for radiation therapy or surgery? And then here, we've actually also moving towards listing on our test report the patient's sensitivity to radiation therapy. So would you indeed benefit? We provide this risk score for you. In this case, in this study that we published, we looked at patients that receive radiation therapy and patients that receive no therapy. And here, in the patients that we use this outcome score that's based on 24 genes. Again, this is research purposes only, but we look at 24 genes that are associated with biomarkers, with DNA repair genes, immune genes, etc. What that means is that if your tumor can repair itself or its DNA, because we just, brush you up on the term DNA, so if your tumor can repair its DNA, then it may not be sensitive to radiation therapy. So your lab comes and he blasts your tumor with radiation, and then this tumor somehow is able to repair itself and repair its DNA, and it keeps on going. So here with this score, if you have a high cortisol score, then you would be more sensitive to radiation treatment. Other stuff that we're also looking at is being able to personalize your medicine as far as your response to certain chemotherapy drugs such as, say, docetaxel or abiraterone. So how sensitive or resistant will you be to these chemotherapy drugs? Next, we're also, like the Cortos post-operative radiation therapy outcome score that I just previously mentioned, we're also developing biomarker signatures that can determine which patients would benefit from hormone therapy. So with that, again, if you have a high ARF score, then you would be more sensitive to ADC therapy. And wouldn't that be handy? Because sometimes, again, you don't want to be having all these treatments and having all those side effects from those treatments. You want to know right off the bat, hey, doc, give me something that really is going to cure me and not just, we're going to do all these therapies and it's no use to me, so why are you giving it to me anyway? So these are some of the questions that we're going to be able to answer with this ABT response signature. And then finally, some of you or some of your family members have had all these different treatments. This seems to be a real aggressive cancer. Your physician has tried everything. Because now we've captured that snapshot or genomic fingerprint of your tumor, you can go back now that your physician has tried everything and you're still metastasizing, and link you to clinical trials that were currently available that would benefit you. Based on the genes that you're overexpressing or underexpressing, will make you decide, hey, he's a good candidate for, say, for instance, this anti-PD-1 therapy that is available. So again, no one has this ability to have this disruptive technology and able to personalize treatment that we can because of, again, that little chip that I talked around, the microchip, that's able to do all of this, collaborating with all the different institutions.